Everything's good. We're good in Alexandria.
Perfect. Perfect, perfect. Hey. I mean, I can. Oh, yeah, I haven't. Okay. Okay. Doo-doo-doo. Okay. So, good morning again. We're going to be talking about pediatric emergency stuff and trauma today. So I want to preface this with I'm not trying to turn you into a pediatric certified ER nurse. You're going to get a lot more stuff in fourth level. I just want to lay a really good foundation here today. Like I said yesterday, we're going to talk a lot about airway breathing circulation. But so don't get in the weeds about like nitty gritty. I feel like your book, kind of keeps it, I don't want to say basic, but, like appropriately challenging and, appropriately in depth. So don't freak out that, oh gosh, this is, new content. This is different. This is challenging. It's going to be all right. So as we talk about pediatric emergencies, we'll talk about traumatic emergencies and trauma, and then we'll also talk about some medical emergencies. Trauma is the #1 cause of death in pediatric patients, unfortunately. I always giggle because I feel like a lot of my lectures are not the like rainbows and butterfly lectures. We talk about a lot of hard stuff in this lecture, especially, and then later, with the Dr. Wood does the end of life and palliative care later in the semester. But so sorry to be the bearer of bad news. But it's not all rainbows and butterflies in pediatrics. Bad things do happen to kids. They do die, unfortunately. But to me, it's one of the best parts about being a nurse is getting to be there during the worst times, the best and the worst times. So with trauma, we're talking about drowning, poisoning or ingestion, and then injuries related to like motor vehicle accidents, ATV accidents, sports injuries, falls, and then non-accidental trauma, which is, neglect and child abuse. And then also we'll, at some point during the semester, if not today, talk about all of these medical emergencies. Miss Harrell talked about, respiratory distress yesterday. We'll hit on it some again today. Cardiac arrest in the presence of respiratory failure. That is, respiratory failure is the #1 cause of cardiac arrest in pediatric patients. So if we can fix respiratory, hopefully we can keep, the heart from giving up. Shock, which we'll talk a little bit about, and you'll get a much heavier dose of in fourth level. So we're just going to lay a foundation today. DKA, which you've gotten some of in second level, we'll hit it again later in the semester. And then I think you get it again some in fourth level as well. Very, very important, very prevalent in peds. Dehydration, sepsis, seizures, and then asthma exacerbation. So again, if we don't cover it today, we'll cover it some other time during the semester, or you'll get it, in fourth level. But with all of these, early intervention is always key to promote favorable outcomes. Some differences in anatomy that are pretty important as we talk about, pediatric emergency and trauma situations. They have a smaller amount of subcutaneous tissue. So, they have less squish to cushion, blows if they get struck in the abdomen or something like that. So, they're going to be more easier, like trauma is going to affect them a lot to a greater extent than it would you and I. And then again, kind of along the same lines, thin abdominal wall and muscle tone. So just less protection, right? If they get struck in the abdomen or somewhere else, they have less, less protection, less of a hard, protective outer shell, if you will. They have a protuberant abdomen. So especially our precious little, preschoolers and toddlers, like Dr. Wood talked about, their little pot belly self, very protuberant. So there's more out there, to be injured. And then, kind of reflecting back that thin abdominal wall, thin musculature. Their rib cage is much more pliable. much more flexible than ours. So what that translates to is if they get struck, in the thoracic cavity, that energy is going to transfer to a much greater extent, like inside that cavity. So if they get struck in the chest, it can potentially cause much more thoracic trauma, to their lungs or maybe even their heart. So we'll see a higher incidence of pneumothoraxes or collapsed lungs, and they can have cardiac contusions, things like that. And then they're fun sized, right? They're much more compact than we are, but they have all of the same stuff inside them, right? So I like to think about this if you're packing, think of packing for a big vacation, and you need to pack, let's say, 10 different outfits. And so you put it in a large suitcase, and then something happens to that suitcase, there's more space within that suitcase. So the 10 outfits are probably more dispersed, right? There's more space in between them. So, if something happens to that suitcase, odds are all 10 of them, all 10 of the outfits might not be ruined, but think of packing the same 10 outfits in maybe like a weekender travel bag, and then something happens to that travel bag. You have a much higher risk of more outfits getting injured, right? Or getting messed up if something happens to that bag. So kind of the same thing holds true with pediatric patients. We can see the same injury, adult versus peds patient, but we've got all of the same stuff shoved in a much smaller container in a pediatric patient. And so we can see, more organs being damaged when we're facing a traumatic situation. So our initial assessment, safety is always going to be first. You can't help someone else if you're also putting yourself in danger. So, when you took BLS, CPR was the first thing you had to do, assess the scene for safety, right? So same thing. We don't ever want to put ourselves in danger, because then we're not going to be able to help anyone. So we assess safety, and then we go airway, breathing, circulation. We're going to assess the need for CPR. So just like with BLS, if the patient's unresponsive, of course. Also, if they're apneic, of course, we're going to, go ahead and start CPR. Or if they're just gasping for air, that's not meaningful respiration. That's not going to do anything to help them. So go ahead and start CPR as well. We're going to, check their pulse. We don't want to take any longer than 10 seconds to do that, right, per BLS guidelines. And then depending on, if they have a pulse or what it is, we'll go ahead and begin CPR, and we'll talk a little bit more about that later. And then we're going to talk about each of these: airway, breathing, circulation, and disability in detail. But just, to kind of clarify some terminology with airway, we're really looking at the patient's ability to ventilate themselves, move oxygen in and out of, their airways, and then subsequently their lungs, right? Breathing is where the oxygenation happened, the beautiful magic of the diffusion of gases, right? Oxygen and carbon dioxide, and that happens lower in the lungs, the, like terminal airways, the bronchioles, and then the alveoli. And then circulation, we're thinking about perfusion, so that oxygenated blood, is it being, distributed and dispersed to the body as it should be. And then with disability, we're looking more so at their neurostatus. So first, we'll look at airway. So with this, again, we're looking at ventilation, right? So this is strictly the movement of air in and out of the lungs. We talked about this yesterday. I don't really care about breathing and, whether gases can diffuse or not if I can't get the air in and out of their lungs, right? If they've got an upper airway obstruction, everything else is all for naught. So with this, we're assessing their airway patency. Is it open? Can they move air in and out? Remember, we talked about anatomic differences, right? Ms. Harrell talked about that. Infants and small children, those differences can cause airway occlusion very easily. And so their airways are very small, right? Think about, sometimes when we're talking about a baby, we're not looking at something much bigger than a regular straw. So it doesn't take a very big throat booger, as I like to call them, to occlude that. And so we'll talk about suctioning, and never underestimate the power of suctioning. That was one of my biggest lessons when I started working peds. So small airway, their heads are also really big in proportion to their neck and their body, right? So it's my favorite part of like infancy is when they're trying to like hold their head up and they just like look like little bobbleheads because their head is so big on their tiny little neck stalk, right? But what that translates to airway wise is it's very easy for their head to fall forward like this or for it to fall back like this because it's much heavier, right? And their little muscles are just not very strong to hold it up. And so, if we have that situation where their airway is very positional, we'll talk about some things that we can do, but that is one of the things that can occlude their airway very easily. Also, the back of their head, their occiput is very prominent. And so that can, especially when we're lying them supine, that can translate to, their chin kind of coming down and occluding their airway that way. And then also their tongue is very big in proportion to their little oral cavity. So especially if neurologically they're starting to deteriorate, that can translate to their tongue kind of falling back in the back of their airway and occluding their airway some. So what can we do about this? We obviously want to open their airway, right? So we can do a head tilt chin lift. So that's when, we just like Ms. Harrell talks about that sniffing position, right? We kind of just tilt their head back ever so slightly and lift their chin a little bit, and that helps to keep their airway open anatomically. We don't want to like shove their head all the way back, right? And we don't want their chin touching their chest. That's not doing anything to open our airway. The one time that we would not do this is if we have a traumatic situation and we're worried about their cervical spine. If they've been in a car accident or a four-wheeler accident, something like that, maybe they've been shaken. Before we're worried about, their cervical spine being injured, we obviously don't want to be, manipulating it very harshly like that, right? We don't want to turn a spinal cord injury from just an injury to a situation where the patient has become paralyzed. We don't ever want to do more harm, than good. So in those situations, we just do what's called a jaw thrust. And your book has a really great picture for this. And you do just like the name says, you kind of just like thrust their jaw forward, like kind of up. If they're supine, you kind of just pull their jaw up, and that helps to open everything without you having to manipulate their neck so much. Positioning is also very important. And I think Ms. Harrell talked about this yesterday too. We talked about infants, they're like suckers, right? They're little bobbleheads, big head on a small little neck. So, how do we want to position them? The infants in respiratory distress or any patients in respiratory distress, do we want to put them in, like a dependent position where they're lying on their back? No, right? That's very uncomfortable. You ever not been able to breathe, had a really bad cold or something, or, even pneumonia, and you're trying to lay flat in the bed? You don't like that, right? It's very uncomfortable. It makes you air hungry. You usually prop yourself up on pillows, right? So with infants, we can sit them up. If we have them in a crib, we can prop them up, elevate the head of the bed. But we can also just, have the parents hold them upright or, have them sit upright if they're, to the point where they're sitting independently or almost sitting independently by themselves, right? But, we want them up. We don't want them flat. Definitely don't want them in a dependent position because that makes it more difficult to breathe. Suction is very powerful. Remember, infants are obligate nose breathers, right? So they've got the RSV, the bronchiolitis, and they've just got snot rockets coming out of everywhere. Their nose is stopped up. They don't quite realize like, hey, I can also breathe through my mouth. And so it gets very difficult for them to breathe, right? So don't underestimate the power of nasal and oral suction. I have pictures of some different suction equipment. Like Ms. Harrell said, please, by all means, don't shove a yonker inside a baby's mouth or their nose. We have a little sucker that we use. And then of course, just our regular suction catheters. And those come in tiny sizes, 5 French, 8 French. Please don't be trying to shove a 14 or 16 French suction catheter down a baby's nostrils. That's not very nice. Airway adjuncts. So when all of these things that we've talked about haven't remedied the situation, we will start to do things more invasively, right? So oral and nasal airways, those are our airway adjuncts. And I have pictures of these on the next slide. These are kind of band-aids to the situation. This is when, a patient's breathing spontaneously, but they're having some kind of airway occlusion. Again, this is a Band-Aid. We're not going to leave a patient, most of the time with the oral airway or a nasal airway in place. This is at that point likely going to be like a bridge to an intubation situation, because if we're having to reach for an airway adjunct, that patient is not maintaining their own airway very well. And then, of course, if all else fails, the patient is not able to maintain their own airway, we will go ahead and elect to do that for them with endotracheal intubation. And like I said, I'll be the bearer of bad news. This happens very frequently with kids. Not uncommon at all for kids to have to be intubated, especially small babies. We're moving into RSV season. If you get to rotate through a PICU in either Alexandria or Shreveport, I promise you'll see a baby intubated with RSV this semester. Sorry, it's sad, but we have to, hurt to help sometimes, right? So then, of course, agonal gasping, grunting, which Ms. Harrell talked about, that's the patient trying to basically maintain their own PEEP, their positive end expiratory pressure, to keep those alveoli open. It's very cute, sounds cute, but we do not like to hear that. That means that patient's struggling. And then, of course, periods of apnea are all signs of inadequate ventilation. We need to go ahead and at that point, step in and assist the patient with bag mask ventilation. So the AMBU bag, right? And we do that on 100% oxygen. So like I said, pictures, just some different airway equipment. On the left, you have oral and nasal airways. They are color-coded by size, which is great. And then on the right is some intubation equipment. So, laryngoscope blades and laryngoscope handle on the top, and then endotracheal tubes at the bottom right. And they come in tiny sizes. Okay, so moving on from airway to breathing. So we've addressed airway. Airway is stable. We've got a patent airway. We're able to ventilate. So now we're going to move on and assess breathing. So again, realize that kids can be respiratory distressed for quite some time before they tire out. So some signs that your patient is at the end of their little respiratory rope and they're about to give up. Bradypnea. We move from, tachypnea and respiratory distress to everything starts to slow down because they get tired. So if you're seeing bradypnea or, of course, apnea, then that's a very, big red flag that they're going down and we need to help them. Even periodic breathing is one of those things that can be normal, but in the light and in the presence of other more worrisome symptoms, we don't really like to see periodic breathing, especially prolonged periodic breathing. That is a sign that the child is getting respiratory tired and they're going to give it up pretty soon. And when lungs go down, the heart's going to follow not shortly after. And so then we're dealing with a full-blown cardiac arrest situation. And we want to try to prevent, we want to try to intervene and turn them around before we get to that point. Of course, if they're starting to become lethargic or unresponsive, and we'll talk about neurological deterioration, but the brain doesn't like not having oxygen, right? So if you're seeing neurosigns and neuro changes, then that definitely means that the patient needs some kind of further assistance. And then, of course, cyanosis, right? So like I said, they can be distressed for a while before they give it up, but when they start to go down, they go down pretty quick. So it's much better to be proactive than it is to be chasing your tail. So when we're talking about breathing, like I said, we're talking about oxygenation, right? This is, the amount of oxygen in the blood. We need enough oxygen in the blood to oxygenate the tissues, right? We also need to be able to get rid of the waste products or carbon dioxide, right? That's the big waste product we're talking about with respiratory. We need to be able to get rid of that via exhalation. And remember that magic happens deep in the lungs at the alveolar capillary level. So flashback to patho when we talked about respiratory. The alveoli are surrounded by the little capillaries, and that's where oxygenation meets circulation, right? And the gases are able to diffuse back and forth. And so if we're not able to pop open those alveoli, there's, if there's inflammation, there's secretions, there's infection, there's the lung is collapsed, whatever may have you, whatever the pathology is, if we can't pop those alveoli open, then we can't oxygenate the patient very well, or they can't oxygenate themselves, and we will also have difficulty doing that. So assessment-wise, for breathing, kind of basic, right? We're assessing chest rise. Is it adequate? Is it very shallow? Is it symmetrical, right to left? Are they working very, very difficult, working very hard? Are they having difficulty breathing, huffing and puffing? What's their respiratory rate? per minute, is it adequate for their age? That's going to be a really big difference for you guys as you move into, and you've gotten some of this in OB, right? Babies, everything's very fast because their metabolism is all jacked up on Mountain Dew. So, when we're looking at vital sign, data, we're always looking at, is it normal within the parameter of their age range, right? So what's their respiratory rate? Is it really, really fast? Are they tachypnic, or are they starting to tucker out? And, are they not quite breathing enough per minute to support their oxygenation needs? And then effort-wise, are they having nasal flaring? Are we seeing retractions, subcostal, intercostal, supraclavicular, suprasternal? Do we see any tracheal tugging? Typical rule of thumb is the higher on the thorax that you're seeing, them pull, and you're seeing accessory muscle use and retractions, the more distress your patient is in. So, I don't love to see retractions anywhere, but I would much prefer to see subcostal retractions than I would to see supraclavicular retractions, or, like suprasternal retractions and tracheal tugging. And then head bobbing as well. And those are things, you see them one time and then you learn like, oh, okay, that's what that is. So then also assessment data, we're going to put them on the monitor, right? So we want continuous cardiac and respiratory monitoring if we're in an emergent or traumatic situation, of course, continuous pulse ox, and we want to have that blood pressure cycling as fast as we can, probably in an emergent situation every 5 minutes, or more frequently if we're able to. So supporting breathing may be all that's needed when the child has a strong, adequate pulse. So if you talked any about in OB, NRP, right? Even if the baby is bradycardic when they come out, what do? Bag them, right? You bag them for, a little bit before you jump to compressing, because just the correlation, respiratory and cardiac in pediatrics, is so strong. And most of the time that pulse is so low because their oxygen level is low as well. And so if you can support their breathing and ventilate them and get that oxygen level in their blood to come up, then the heart gets happy again and it'll beat and it'll do the things that it needs to do. So if, they've got a good adequate pulse for, their age range, then we might just need to bag them until we can figure out what's going on. So again, how do we support breathing? The things we talked about, right? Basic positioning, suction, managing that airway, making sure that it's open. But then also at this point, if we need supplemental oxygen, we're going to go ahead and do that. And there's lots of different ways that we can do that, right? Nasal cannula, non-rebreather masks, Venturi masks. And just, remember you have to work within the confines of your liter flow on those, right? Like nasal cannula, typically we're maxed out at 6 liters per minute. So if we need more than that, then we kind of have to go, up in a stepwise fashion. You're also going to see in clinical this term, we use different things in peds. We use things called, high flow nasal cannula. So some different brand names are like OptiFlow, Airvo, Vapotherm, different things, all like synonymous for high flow nasal cannula, where we can go to much higher liter flows that the child might need. So be excited. You'll promise you'll get to see that in clinical this term. We can also use BiPAP, CPAP, lots of different things to administer pressure and oxygen if we need to. And you'll see those, on the floors. And then you'll also see those if you get to rotate to PICU or NICU. Very, very common. And then, of course, if, we have to, we'll, intubate the patient, secure that airway, and we can also deliver pressure and supplemental oxygen that way as well. So bagging, we kind of talked about this, right? If you're going to work in peds, you need to be comfortable bagging a patient, because cannot tell you how many times I've had to do it. Whether you work ER, or pediatric ICU, we frequently have to bag kiddos. So we want to make sure we have the right bag size. They do come in different size. We don't want to be using an adult bag on an infant or a pediatric patient, right? That's going to be too much volume. Too much volume, too much pressure. We can pop a lung. We don't want to do that. Also the right mask size. They come in, infant, pediatric, and then adult sizes as well. And there's like various different infant sizes, preemie masks, that kind of thing. If you work in this area, you'll become proficient in all of that. I have pictures on the next slide, I think. And And when we're bagging only to get chest rise, right? We're not like slamming the whole, bag's worth of volume in their chest. Because again, we don't want to use too much volume, too much pressure, and cause inadvertent damage. Make sure you're suctioning if you need to. Again, if the airway is not patent, if it's occluded with secretions, you're not doing anything bagging them because you're not able to get the air in and out. Make sure your bag is hooked to oxygen. Should go without saying, right? But can't tell you how many times seen honestly not great outcomes because we're bagging a patient on room air and, someone forgot to hook the bag to oxygen. Doesn't do you a whole lot of good. Rescue breathing in pediatrics is one breath about every, 2 to 3 seconds. This is different than what you probably learned with adults, typically like one breath every 5 to 6 seconds. But again, respiratory rates are higher in kids. So we breathe for them faster, just like they breathe faster, right? And then again, at this point, if we're bagging, this is likely a bridge to intubation. We don't just bag a patient indefinitely, right? So just some pictures here, the different size ambu bags on the left, different suction equipment. And then this picture for the EC hold is in your book. This is the correct way to hold, a mask on a patient's face. And it's just called an EC hold because the way the fingers are positioned. And so, if you're right-handed, you can use your right hand. So your middle finger, ring finger, and pinky make the E, and then your thumb and pointer finger make the C. And so the C goes around, the circular part of the mask, and then the E fingers rest under the patient's chin, like that. And this is called an EC hold. And you'll learn that when you graduate, do ACLS, all the things, they teach you that. All right, so moving on to circulation. So we've addressed airway, it's patent. We've addressed breathing. Oxygenation is, satisfactory. We're good with that. So we're going to move on to circulation. So with this, again, we're looking at perfusion, right? So kind of common sense assessment stuff, right? Pulses. So we want to look at central pulses and peripheral and compare the two, right? But if we've got a patient that's in a stress situation, what does our body do when we're under stress? It shunts everything back to our core, right? We have that fight or flight response, and all the, epinephrine and norepinephrine from our adrenal gland starts to circulate. And so it shunts everything back to our core because we want to make sure we have enough blood and warmth and oxygen and nutrients for our core organs, right? We usually can't live without those. So not uncommon for peripheral pulses to not be amazing, or for them to be different in comparison to our central pulses. But, with central pulses for infants and toddlers, those are brachial and femoral pulses. And then peripheral is the same, right? Our radial and then our pedal pulses. We also want to auscultate them. Our central pulses, make sure we're actually, we have actual pulses. We're not just relying on a monitor, right? And then if we can't palpate them, then we can usually hear them, right? So especially peripheral pulses, if we can't palpate them, then we want to make sure we Doppler them, make sure they're at least Dopplerable. And we'll go ahead and mark them just so then, if things start to go sideways, we know, like, I had a Dopplerable pulse here 5 minutes ago. I no longer do. So now our situation is deteriorating, right? And then if they're not Dopplerable, of course, if a pulse is not palpable, that's very much a reportable situation, right? Anytime we're having a Doppler pulse, we need to make sure we let the provider know that. But then if we're not able to Doppler it, then obviously that's very much an emergent situation as well, because circulation is deteriorating, right? So what are good pulses? Like usually 2+, right? At least 2+. Anything less than that, we don't love. And then cap refill, normal, 2 to 3 seconds, right? And we want to check that peripherally. We also want to check that centrally, just because, again, that shunting mechanism might be prolonged in the periphery. But as long as I have decent cap refill or good cap refill in my core, I'm not as worried as if I have, kind of crappy cap refill all over, right? And then what does delayed cap refill mean? Circulation is not quality, right? The perfusion of the tissues, or the reperfusion of the tissues, is what you're seeing whenever you're testing capillary refill. Heart rate and blood pressure. We said we were going to put them on the monitor. We're assessing those frequently, if not continuously. Comparing them. Is it age appropriate? Are they tachycardic? Are they bradycardic? Are they hypertensive? Are they hypotensive? And we'll talk about this more when we go into cardiac, and then when you listen to the trauma recording for your orientation assignments, the gentleman that does that presentation talks about this very, very well, and he talks about this, just in relation to trauma. But kids are different cardiovascular wise than us. They don't have the reserve that we do. So children can compensate with their heart rate. They can't really compensate with the contractility of their heart. So think back to A&P and patho. Cardiac output is heart rate times stroke volume, right? So they don't really have a whole lot of wiggle room with their stroke volume because their cardiac muscles are immature, right? And so they can't stretch that rubber band of the heart muscle like you and I can to try to increase their stroke volume. They have a limited ability to do that. So stroke volume is relatively fixed. And we said, especially infants, and small people, small pediatric patients, the smaller the patient, the worse this situation is. They already function at a very high heart rate, right? Because their metabolism is just very, very high. And so their heart rate has to be high to meet that metabolic demand. So what does that really tell you about my cardiac output situation if I don't have a whole lot of means to increase my stroke volume? And in a lot of situations, I kind of already function towards the top tier of my heart rate. I don't have very much means to increase my cardiac output if things start to go sideways, right? So what that means to you is cardiac wise, kids will go down quickly. Heart failure develops very quickly in pediatric patients because they don't have those compensatory mechanisms, or they don't have them to the extent that you and I do. Also, this means that if bradycardia is present, you need to move quickly because that means they're going down and they're going to go down fast. And if you are seeing hypotension, you are already behind the 8 ball because they will hold on to that blood pressure until they kind of can't anymore. And so if you're seeing low blood pressure, that is a late sign of deterioration and things are going to start moving quickly. So you need to start moving quickly to try to turn the situation around. Also, don't forget to think about blood loss. Is it a trauma situation where, they could be bleeding somewhere? And at that point, then that kind of, we're going to turn to blood products more quickly than we are just going to be turning to fluids, right? So we also want to look at their skin coloring. Are they pale? Are they mottled? Are they pink? We like when our patients are pink, right? We don't like whenever they celebrate 4th of July and they're turning, red, white, and blue. And then, of course, cyanosis is never good. So all of those reflect basically poor circulation, poor oxygenation, right? Stress. And then temperature, central versus peripheral. Again, with that stress response, peripherally, they may be kind of cool. But I like that more than them being cool at their core as well, right? Temperature, and they could also be febrile if we're dealing with like an infection or a sepsis situation, right? But a lot of the times they will come in, hypothermic, especially if they are very, very sick. Drownings will frequently come in hypothermic. Sometimes or honestly, all of the time, I would prefer my patient to be febrile than hypothermic. Hypothermic typically means they're much more sick than when they're febrile. And we want to make sure we get a core temp, right? So we'll get a rectal temp, and a lot of times we'll monitor this continuously with either a rectal probe or an esophageal probe. We can give, warmed fluids, warmed blood products. We want to turn the heat in the room all the way up if they're cold. Take off any cold or wet clothes, of course. And then we frequently use something called a bear hugger, which is like a forced air warming blanket. They use these in surgery a lot, just because it's so cold in there. And then, of course, just traditional warm blankets. Sometimes that's all it takes. And then, of course, with circulation, we need to talk about when to start compressions. Nobody wants to be the one to do it, but if it needs to be done, you just got to do it. So young children and infants, we need to start compressions if their heart rate is less than 60 and or they are showing signs of inadequate perfusion. Inadequate perfusion, I mean their blood pressure is in the toilet and the heart rate is starting to follow. Inadequate perfusion as in they are losing consciousness neurologically or they are unconscious neurologically. These are all signs that vital organs are not being perfused enough with their native blood pressure, and we need to help them with that, okay? So just pictures, all the way to the left is a blood warmer or a fluid warmer. Middle picture is a bear hugger, or middle and right, bear hugger, the forced air warming blanket. We can, regulate the temperature output on that. All right, so next is disability assessment. So if all the others are A-OK, we've stabilized all the other ones. We're going to assess their neurostatus. So altered mental status or neurological alteration is extremely common in traumatic or emergency situations. And it's not always so much that we're worried about their brain per se. We're worried about their ability to protect their airway. Because, remember all of the cranial nerves travel from the brain down to the rest of the body, right? And so if they're not able to, swallow, cough, vomit effectively to protect their airway, then we can have a potential airway compromise situation, right? And they can aspirate. And when we have an aspiration pneumonia situation on top of whatever it is that they came in for, that just really, really exponentially increases their chance of morbidity and mortality. So we really try to prevent that, at all costs. So our rule of thumb here is if a patient has a GCS or a Glasgow Coma Scale score of 8 or less, definitely less than 8, we intubate, because at that GCS level, the patient is very much not with it. They will not be able to protect their own airway. We're also going to assess their level of consciousness. We can do that multiple ways. There's different tools. One of the more frequent ones is the AVPU. It's quick, fast, and dirty. Basically, at that point, you're looking, is the patient awake and alert, responsive to you as usual? Do they only respond to verbal stimulation? Do they only respond to pain? Or are they unresponsive altogether? Again, GCS. We do have pediatric scales. If you don't have access to it, the adult scale can be used. There's obviously just going to be some differences, mostly with the verbal category, just because we don't necessarily expect a baby to be, completely verbal, right? Also, we can't really assess a baby's orientation, to person, place, time, situation. A lot of times at best, we can, determine, do they feel comfortable with the caregiver that they're with? Does it seem that they're oriented to their caregiver? Same with, small, toddlers, preschoolers. But GCS looks at eye-opening, motor, and verbal response. There's 3 minimum score, 15 max score. So obviously the lower the score, the more severely neurologically affected the patient is. And then, like we said, intubate at, less than 8 for sure. And if the patient's not on any sedation and they have a GCS of 8, then a lot of times that's going to trigger a call to LOPA, which is the Louisiana Organ Procurement Agency, just because at that GCS level, brain death is pretty likely, depending on the situation. PERLA, of course, we're going to assess their pupils. We want to make sure they're equal, round, reactive to light. They accommodate, they do all the things that they're supposed to, and they don't do the things they're not supposed to, right? We don't want them to be fixed and dilated. We don't want them to be non-responsive. We don't want them to be unequal. If they are any of those things, that's worrisome, and we definitely need to let the provider know. And then, of course, rule of thumb, this should just be review. Anytime a patient is lethargic or neurologically altered, always a good idea, one of the first things, check their blood sugar, just because sometimes it's just their blood sugar is low, right? And that's an easy fix. That's a quick fix. So if they're hypoglycemic, which your book defines as, a blood sugar less than 70 milligrams per deciliter, we're going to treat with IV dextrose. And then once we get that up, recheck 15 minutes later, and we get it up to an acceptable level, then we'll go ahead and start, IV fluids, maintenance IV fluids with dextrose, and that's typically D5W or D10W, or D5 normal saline, some kind of maintenance fluid with dextrose, so that we can maintain that sugar until we can, get them eating again and all that good stuff. So this is just a picture of, your modified GCS for infants and children. If I, asked you to use this on the exam, I would provide this for you. And of course, remember to assess and treat pain appropriately, that does fall, you know, within the neuro system as well. So our general interventions, in addition to what we've talked about, meds in these situations. Your book has the pharmacy 35.1. You know, I don't want you like memorizing dosages or anything like that. You know, never a bad idea just to look and see like what's the general mechanism of action, you know, that kind of thing. But these are your emergency meds, right? This is atropine for bradycardia. This is epinephrine for hypotension. You know, all of our different vasopressor medications that we use. So yeah, like I said, epi, you know, norepinephrine or Levophed, dopamine, dobutamine, you know, all medications that increase heart rate, increase the blood pressure, increase the contractility or the squeeze of the heart, to increase perfusion. Narcan, of course, unfortunately, that's becoming more prominent. We're having to use that more in our pediatric population, just, you know, like we are in general, with the, you know, human population. Atropine, like we said, for bradycardia, and then we talked about dextrose. So these are weight-based, of course, like everything else in peds. But, you know, a lot of times these kids come in from, you know, ambulance and like coding in progress, right? Or like deteriorating in progress. Like, are we going to stop and be like, hold on, let me zero the bed. Let me, you know, let me get an accurate patient weight. Like, you know, excuse me, kiddo, can you like stand on this scale for me? Absolutely not, right? So what we use is called a Broslow tape. And I have a picture of this on the next slide. So basically what it is, you know, we lay the kiddo on the stretcher, you roll the Broslow tape out based on, you know, their length. It gives you like an approximate weight range that kid probably falls in. And it's color coded. And then you'll find like ER and trauma, like everything in the crash cart is color coded. And so that way, you know, if they're like Broslow red, then like there's this little chart and it gives you the appropriate dosages for all your emergency medication. It gives you the appropriate sizes for Foley's, NG tubes, suction catheters, ET tubes, all the things. So you're not having to like think about hard things as much whenever you're in like a, what does Miss Laborde say? A sphincter tightening situation. You know, kind of takes some of the stress off. So Broslow tape, we use those. And then, of course, with these meds, you've got to treat the underlying cause of bradycardia or hypertension, or you're really just putting a Band-Aid on the situation, right? Okay, let me make sure I didn't miss anything. Okay, so then IV fluids. So if we've got poor perfusion, we're seeing those signs, then we want to give IV fluids, right? We're going to give fluid boluses of isotonic solutions. So that is what? Like normal saline? Yes. LR? Yes. In Shreveport, you will see Isolite, Plasmolite. Those solutions, those are isotonic as well. Dextrose solutions, not isotonic. You know, other things like colloids, stuff like that, not isotonic. We want isotonic fluid boluses, so we're not causing massive fluid shifting in the brain, right? So we'll do this 10 to 20 mils per kilo, typically over 20 minutes or less. Whoop, sorry. And we're going to use something that we call push-pull technique. Super funny. I worked a shift Saturday, and we actually had to do this because we got a kiddo very much overwhelmingly septic, was okay until she super was not. And then we look up and blood pressure 60/30. Cool. We were already, you know, running a liter fluid bolus on the pump, but she obviously needed more than that, right? While we're, you know, working in the background to get epinephrine, norepinephrine, all these other things, you know, situated and hung so that we can help augment her circulation. But we use what's called push-pull technique. I have a picture of this on the next slide, and there's also a video. You basically use a stopcock so that you can quickly pull with like a large syringe, like a 60 ml syringe. You can pull fluid from your bag with tubing, switch your stopcock the other way, and then push it very quickly in the tubing, you know, to the patient. So you're able to just like very much rapidly bolus the patient with fluids. So just rule of thumb, we'll typically give about 60 mils per kilo of fluids before we start turning to vasopressors or inotropes. At that point, we're really just diluting the patient's blood, right? If we're giving them massive amounts of fluids. And then, of course, we're assessing cardiorespiratory status. While we're doing this, if we start to see any signs of fluid volume overload, you know, jugular venous distension, we're auscultating crackles in their lungs, then we need to hold off, right? We don't want to put them in a fluid volume overload situation and add insult to injury. And then, of course, like we talked about, be thinking in the back of your mind, should we reach for, blood products sooner? It's their gunshot wound. Could they potentially have internal bleeding? Isotonic fluids aren't going to do too terribly much for that, right? They need blood. They need surgery and they need blood. So at that point, we're going to reach for, blood products and packed red blood cells and blood transfusions much quicker at that point. We're not just going to pump them full of 60 mils per kilo of fluid. And we'll talk about this with cardiac, but cardiac patients, any patients with a cardiac history, of course, we want to know that ahead of time if we can. But with those kiddos, they're not going to tolerate those large volumes of fluid, right? Their little heart's already struggling. So we're typically going to do about half of that. So probably 5 to 10 mils per kilo over about twice the time. And we're going to be much, very much astutely assessing their cardiorespiratory status. And we have a much less threshold to, hold off on fluid boluses with them because their little hearts just aren't going to tolerate it. As far as IV access goes, this is frequently a situation where, at a certain point when we've got things stabilized, we're going to get a central line. But if we're not able to get a peripheral IV, which is frequent in this situation because this is a sick kid, right? Their vascular system is very much vasoconstricted. It's hard to throw an IV in a kid to begin with, much less when they're, septic and kind of trying to die on you. So moral of the story, don't sit there and just stick and stick and stick and stick and stick. We need IV access. IV drugs are a lot more effective than other routes. And so if we cannot get an IV in a reasonable amount of time, and I can't give you a, definition of a reasonable amount of time, but, we need to go ahead, if we can't get a peripheral IV, we need to go ahead and do an intraosseous IV, okay? That's called an IO, and that's when we literally are able to get vascular access through their bone into their bone marrow. Very similar, in theory and, administration as IV. We can give fluids, we can give meds, we can give all the things. Can't get blood, but, we can give emergency meds and things that we need to. And then later, once we've kind of resuscitated them a little bit, then maybe we can get a peripheral IV. The provider can put in a central line, but we've got to have access, especially in an emergent situation. ROSC care, that's return of spontaneous circulation. So this is after we've coded a patient. All I really want you to know with that, your book kind of goes into detail about it. Don't get in the nitty gritty. Basically, our goal is to prevent secondary tissue injury from the hypoxemia and the ischemia that likely occurred while they were down, right? While they were in cardiac arrest. And so we do lots of things in the ICU to try to, mitigate damage from that hypoxemia and the tissue ischemia. And then just other general interventions. We talked about fluids, inotropes, oxygenation, ventilation we've talked about. We want to make sure they have normal carbon dioxide levels. So our typical level on our blood gas is 35 to 45, right? So we'll, tweak ventilators and things like that to try to maintain that. That's a little bit advanced. TTM is targeted temperature management. This is whole body cooling. You'll see this in the NICU after they've had like a hypoxic ischemic event or a really bad delivery. We'll also, as of right now, there's no like official evidence, like official recommendation that there's benefit to do it in pediatric patients, but there's also no evidence to say that there's no benefit, so you will see it done. And basically with that, we're cooling them with the ultimate goal to cool their brain, to decrease the metabolic demand for their body to try to recover from that, that cardiac arrest insult, that hypoxic insult. Plus or minus antibiotics if we're dealing with an infectious or septic situation, plus or minus blood if we need. Plus or minus steroids, especially if we've given lots of fluids and we're maxed on those vasopressor medications. We'll give steroids a lot of the time. And then continuous renal replacement therapy is pretty much like continuous dialysis because very, very common to have an acute kidney injury situation after we've had a cardiac arrest or if, perfusion just has been really, really poor for a while. So examples of Broslow things, you can see all the different colors. So again, red, the approximate, or estimated patient weight is 8 to 9 kilograms, approximate age, 6 to 11 months. Broslow red gives you all the resuscitation, all the, all the things for an 8 and 9 kilogram kiddo. So work smarter, not harder. Right? And then these are, there's a video of the push-pull technique if you would like to check that out. And then, you know, if you're not familiar with what an IO is, there's a video for that as well. So education and emotional support. This is a big part of ER and trauma. This is a big part of peds in general, right? Nursing in general, but especially peds. Understandably so, people get sideways when their kids are hurt or sick, right? It's very difficult to deal with. So we never want to tell a family that everything will be okay. We don't know that. I've seen kids walk into the PICU and not walk out. Things happen. It's very unfortunate. You know, don't put yourself in a situation where you have to eat your own words. Be present, of course. It can be very uncomfortable. It can be very difficult. Being there is better than not being there. Use open, honest communication. Describe things in simple terms, of course. And if able, you know, describe things as they're happening. You know, we always want to communicate with a mom, a dad, a caregiver, what we're doing with their kid. Of course, in an emergent situation, things happen very quickly, right? But we still want to try to describe what we're doing and what's going on as best as we can. And, you know, bonus points if we're able to dedicate like an entire, you know, team member to stay with the parents and explain what's going on. Of course, we're going to respect their culture and beliefs. You know, if they don't believe in blood products, we respect that. You know, any religious beliefs, things like that, gets very difficult, gets hairy sometimes, but we do have to respect that. Hard conversations, very common in peds, but involve your resources. Child life specialists are wonderful with the difficult conversations with family and difficult conversations with kids. Most hospitals have a chaplain in-house or on call if needed, and then social workers are really great at that too. I have a firm belief, and if you were to ever work with me, I'm very quick to say, I don't get paid enough to have that conversation, you know, and I don't mean that in an ugly way, but there are other people who, you know, that's part of their job description. They're specifically trained to handle that with grace and dignity. And so, you know, definitely involve them whenever you can and when you need to. Maintain privacy. People are very nosy. If you've ever walked through an ER, especially, you know, at Ellick and Shreveport, y'all are bigger areas, but we have like one small ER here, and people are real nosy. Real nosy, and people find out real quick, so-and-so's in the ER, you know, this happened, that happened, whatever. So pull the curtain, right? Don't be coding somebody's kid or coding someone's family member with the curtain wide open if you can help it. And promote family presence when appropriate. It might seem a little bit counterintuitive. You know, in movies and TV shows, you know, they always, you know, pull everyone away, right? And certainly if they're falling out on the floor, acting sideways, cutting up, then yes, we remove them from the situation, have security remove them, the supervisor remove them, because we need to be able to do what we need to do with the kid to try to save their life. But evidence has shown and studies have shown that when family members are able to watch, especially in, you know, like a cardiac arrest situation, we're trying to resuscitate someone's child. Studies have shown, research have shown that when we allow the family or allow the caregivers to be present, it brings them closure. A lot of the times when they see what we have to do to try to get their kiddo back, and especially if we can see it's turning futile and we're not going to get the child back, a lot of the times the family will start to sense that as well, and they don't like watching what we're having to do. They don't like seeing that happen to their child, and they'll ask us to stop. And so, you know, and like I said, it brings a lot of closure, as opposed to, you know, we ask them to go to some other room, or we force them to go to some other room, you know, down the hall, and they think that everything is okay. They know that we're working on their child, but then, you know, two strangers come in and, you know, say, I'm so sorry, we did everything we could, you know, when they thought their kid was going to be okay, right? And, you know, they didn't get to, you know, see their kid in those last moments. And so, you know, if we can give them a job, that's great. Of course, if we're coding, it's not really realistic for them to be holding their child's hand or stroking their head, right? But if it's not emergent and, you know, it's appropriate, then let them stay with their kiddo. Let them, you know, hold them, give them a job, let them feel, you know, let them feel needed, let them feel purposeful. This is a very much out of control situation for the kid and the parent. Then of course, be aware of your own feelings. Nursing is hard. Losing a patient's hard. Losing a baby, losing a kid is impossible. So, debriefing is a really great thing that we do, where we talk about, what happened? What could we have done different? Could we have done anything different? Was this unavoidable? Are we okay? How do we feel about this? And a lot of hospitals now post-COVID have resources free and available to their nurses just because of the things that we, see, deal with. And then of course, self-care. How am I on time? So we're 56. So let's get through respiratory arrest, and then we'll take a little 5-minute break and then move on. So respiratory arrest is, of course, as it sounds, right? We've progressed from respiratory distress to now they're not doing it anymore, right? Or, it's imminent. So our etiology, this right here is typically how I will set up my slides for my PowerPoint with etiology, patho. I love patho. I'm a patho freak. I find beauty in it, but patho is important because if you know how things are normally, and then you understand physiologically what's going wrong, it makes a lot more sense. And then you understand on a much better, deeper, greater level why we're doing the things that we're doing and why they should work, and maybe why they're not working if they're not working. So this is typically how you'll see my slides set up when we're talking about disease processes. So etiology means cause, right? Your book has table 35.1 that goes over a lot of different causes of respiratory arrest because there's a bunch of them, right? Could be, foreign body aspiration, they're choking on a grape, a marble thing, kids are wild, y'all. I have the stories that we could tell you. Bronchiolitis, croup, asthma, seizures, shock, drowning, neurological injury, traumatic brain injury. The list goes on and on. So lots of different causes, but pathophysiologically, the issue is the same. There's impaired ventilation and or likely both impaired oxygenation to the point where the child's not able to maintain what they need respiratory wise. Like we've talked about, typically this is preceded by a period of respiratory distress. Eventually they get tired out and then they'll present to us in respiratory failure. We like to catch them before this, but sometimes it just be like that, right? The parents didn't really know what they were supposed to be looking for, and they come in and they're on the brink of respiratory arrest. And it will lead to cardiopulmonary arrest if it goes untreated, which they come in, coding as well because of this pretty frequently. Our presentation here, a lot of what we've talked about, they'll likely be altered, if not unconscious. We've got tachypnea that progresses to bradypnea, then apnea. Cyanosis, increased work of breathing that eventually progresses to very little effort to breathe. Gasping, agonal breathing, or complete apnea, right? Our interventions here, everything we've talked about. We're maintaining our airway, addressing our breathing, augmenting our circulation. We are administering oxygen via bag mask ventilation in this situation, and this is a bridge to intubation. So we're bagging or respiratory therapy. Respiratory therapists are our best friends in peds. You're going to see a ton of interdisciplinary collaboration. I would not want to do my job without a good respiratory therapist working peds and PICU, and then also NICU. We work very closely together. But so we're bagging or respiratory is bagging. Everyone is working behind us, quickly. Providers coming to intubate, and we're going to go ahead and place the kiddo on the ventilator until we can determine what the issue is and how can we fix it. Can we fix it? How long is it going to take to fix it? Also, good education topic here, especially if a kid has gone down before, or we've got some kind of comorbid condition where respiratory distress progressing to arrest is likely to occur frequently. It's a good idea for parents to be CPR certified. I think it's a great idea for everybody to be CPR certified, but especially parents of kids that this could happen to, because I cannot tell you how many times, and I'm sure Ms. Harrell is nodding her head and Dr. Wood is nodding her head as well, how many times a kid's life has been saved because a parent knew how to do CPR. And had someone not been there that knew how to do CPR, kid would have died, but they were able to save their life. So it really does save life, guys. Okay. A little on the dot. Let's take a 5-minute break and we'll come back and talk about super depressing, submersion, drowning. All right, I've got 11:06. So we'll come back. Okay. So let's talk about a submersion injury or drowning. Um, Super common, unfortunately, especially during the summer months, but we honestly see it year round. So it is one of the leading causes of death in the pediatric population, if not the leading cause of death in our pediatric patient population, especially with males who are 1 to 4 years old. If the family lives near water, on the river, on the lake, has a pool, etc. There's a lack of barrier, no floaty use, or if the patient has a neurological or cardiac condition, maybe they have seizures and, they know how to swim, but they seized in the water. Or, their blood pressure dropped in the water, they went bradycardic in the water, a diabetic whose blood sugar drops in the water, et cetera, et cetera. So our etiology and patho here, of course, etiology is we're submerged in water, right? But basically what's going to happen is the airway gets submerged. They'll hold their breath. Anyone will hold their breath as long as they can, but then eventually gets to the point where they can't hold their breath anymore. Start to panic. They aspirate water. Our airways are touch-me-nots. So our airways will start spasming. Obviously, oxygen levels start to drop in the blood. Carbon dioxide levels start to rise, which contributes to decreasing level of consciousness. The patient gets more acidotic. In OB, you probably learned about surfactant, right? In the baby's lungs, we need surfactant to be able to pop those alveoli open. So that's a big issue when we have infections or aspiration or anything like that, is the surfactant gets either washed out or deteriorated, and those alveoli become very stiff and they can't get popped open so oxygenation can occur. And that's kind of what happens here, is that surfactant gets washed out, and so alveoli can't pop open, oxygen and carbon dioxide cannot diffuse. The patient will lose consciousness, they'll become bradycardic, and eventually asystolic. So hypoxic brain injury is obviously our big worry here, right? Cardiac arrest, nothing's getting oxygen. Brain injury will begin within 5 minutes. Within 5 minutes of inadequate cerebral oxygenation, right? We do see better outcomes in cold water. I was reading a study, and guys, this just blew my mind, blew my whole mind. They were saying that there have been reported cases where, because I don't know if you guys have seen that Grey's Anatomy episode where, like Meredith, she drowns in the cold water, right? And everyone's like, she's not dead till she's cold and dead, or she's warm and dead, right? And it's true, because we see such protective, neurologically protective effects of cold water. I was reading on UpToDate that, literally there have been reports of them coding patients for just hours and hours and hours, like 12 hours on end, until they were able to get the patient's temperature up to an appropriate level. And, like they got return of spontaneous circulation, and the patient was neurologically intact afterwards. And that was just blew my whole mind. So we see better outcomes in cold water, better to drown in cold water than warm water, because of, the decreased metabolism and the protective effects neurologically. Typically 10 to 15 minutes down, and by down, I mean like submerged under the water, aspirating, not breathing, things like that, is the max amount of time that we will see a good outcome. But this is exceptionally variable. And the presentation is very, very variable as well. We've seen, near drownings come in and they just need, some supplemental oxygen. Whereas on the other side of, that scale, we see them come in honestly and very bluntly, completely, brain dead with fixed and dilated pupils, and we wind up withdrawing care, unfortunately. So it's just very, it's very dependent on what kind of water, what the temperature of the water was, how long were they down, how quickly was CPR started, et cetera, et cetera. We also worry about pulmonary edema, of course, and ARDS, which is acute respiratory distress syndrome, where that surfactant gets washed out and it becomes very, very difficult, borderline impossible to ventilate them and oxygenate them. And then, of course, pneumonia, more so if they drown in dirty water. Secondary drowning, we do worry about, even if it's just, a situation where they didn't go completely asystolic, likely didn't aspirate very much water, they can still have, negative effects from a near drowning event. So we do still want them to come to the ER. And a lot of times we'll monitor them, for at least 8 hours, I think the standard is, but a lot of times they'll monitor them, 12 hours, maybe overnight, just to make sure they're not going to start to decompensate respiratory wise. We'd rather them do that in the ER or on, the peds floor or the PICU, right? Then we would rather them do that at home. So our interventions here, while drowning is a trauma, it's managed medically because of the things, that we said it can lead to: anoxic brain injury, pneumonia, pulmonary edema, ARDS, all those things. So of course, BLS, this is a great situation. Can't tell you how many kids have been saved because, they were drowning and were pulled out of the pool unresponsive and somebody knew CPR. Because it's still, in best case scenario, minutes, right, before paramedics, EMTs are going to get there. So we'll continue, CPR in the ER if it's in progress, of course, hook them up to continuous monitoring of all the things. Most of the time, we'll get a chest x-ray just to see what is the aspiration situation looking like. Of course, supplemental oxygen. If not, intubation, ventilation, all the things. If they are, they do have an advanced airway, meaning, they are intubated. Usually we see very high ventilator settings for these kiddos because that surfactant has been washed out. They need higher pressure to keep those those alveoli open. They need higher PEEP to keep them open. Likely boluses, plus or minus vasopressors or inotropic support. Those are the, epinephrine, dopamine, dobutamine, all those medications we talked about. Targeted temperature management. Like I said, this is frequently they'll come in hypothermic, either from drowning in cold water or just because of neurological insult. Because remember, our body's thermostat is hypothalamus in the brain. So we will cool them a lot of the times, and then if they don't elect to do whole body cooling, we want to rewarm them slowly. And then maybe plus or minus antibiotics, depends, like I said, what kind of water they drowned in, if it was clean or if it was dirty. But the biggest thing with drownings is education on how to prevent it. Oh, sorry. Okay, why is it now? There we go. It wants me to use the mouse now. So lots of education. There's lots of different mnemonic devices. Basically, the silent mnemonic on the right is saying all the same things that this graphic says on the left. These are all just like preventative mechanisms to try to prevent drowning. So, swim lessons, either formal swim lessons or there's something called ISR, which is Infant Swim Rescue, where they teach even infants how to, hold their breath, roll on their back, and swim, float to a certain extent to try to get to the side of the pool. I install alarms, house alarms, gate alarms, pool alarms. There are alarms that will go off if, they sense like a splashing sound in water, which is really great. Layers of protection. So fences, it is the law in Louisiana. If you have a pool in your backyard, there has to be some kind of fence, some kind of barrier around, the pool. Not saying the entire yard has to be fenced in, but there has to be a barrier around the pool. So gates, pool covers when not in use, education on all of these things, and an emergency plan. If someone goes in the water, do we know CPR, all those things. Eyes on them all the time. And, this is a very important thing because I will tell you, it only takes a couple seconds for a kid to get in the water. It only takes a couple seconds for them to get out of your eyesight, and it takes a very little amount of time for this to happen. And so it's almost one of those things, like it's like handoff report. It's like SBAR. It's like, I am watching, my oldest son's name is Cameron. I am watching Cameron in the pool right now. Or if I'm trying to hand off responsibility of that, like I am going to the bathroom, you are watching Cameron in the pool until I get back. Just like over communicate, because like I said, it only takes a couple of seconds for a kid to reach in to try to grab a toy out of the pool, and reach and fall in the pool and it happens. Never leave them alone, of course, not just in pools during the summer. Like I said, we see drownings year round, taking care of a lot of drownings from bathtubs. You know, kids love the bath. It's fun for them to play in. And there's this false sense of security that, you know, they'll be okay. And, you know, I've seen a 6-month-old, you know, 7-month-old, 8-month-old that was left in the bathtub playing and drowned in the bathtub. And then T, touch. So especially if they're little bitty, right? Have hands on them, be able to touch them at any point in time. Okay, now it's okay with the space bar. So shock, we're going to cover shock like kind of at a very foundational level. You're going to get a much heavier dose of shock in 4th level. So I just want to, you know, really lay a good foundation for you here. So there's 4 different types of shock: hypovolemic, obstructive, cardiogenic, and then distributive. So just be, you know, like in general, familiar with, you know, what the different types are. You don't need to get into the nitty gritty of, you know, like compensated versus uncompensated and all the different stages and all these things. But your book has, you know, tables with the different types, and then also box 35.2, some great health history questions to ask when a child presents in shock. So our etiology, of course, is going to depend what type we're dealing with, right? And then patho, you know, I really want you to understand the patho, really want you to be familiar with the patho and understand what's going on so that you can bring that with you to 4th level and further apply it. So patho here is blood flow or perfusion and oxygen delivery are not able to meet the metabolic demand of the body. So we get a decreased ability to remove the byproducts, the waste products of metabolism. The big one here is lactate. So lactic acid, right? So that levels of that will build up. This contributes to metabolic acidosis. Lack of oxygen and high levels of carbon dioxide are going to lead to cell, tissue, organ death, right? Because tissues are made of cells, organs are made of tissues. This is a building block, right? So those organs, all those things start to die, and this eventually is going to cause death in our patient if we don't identify it and start to intervene, right? So again, you know the patho, be familiar with the different types, but I really want you to be most familiar with hypovolemic because that's typically the one we're going to deal with in the pediatric population. So hypovolemic, this is a volume problem. So we've either lost blood volume or we've lost plasma volume. So this could be hemorrhagic shock, so blood loss, or fluid and electrolyte loss, so nausea, vomiting, diarrhea, burns, diabetic ketoacidosis because they pee off a ton of fluid, and then, you know, the insensible losses for them breathing so fast and so hard. Nephrotic syndrome, which Miss Harrell will talk about later with GU, and then sepsis. Obstructive is a blockage problem. So we have reduced or blocked blood flow from the heart to the great vessels. Our great vessels are our pulmonary artery and our aorta. So with this, we've got maybe a pulmonary embolus, a tension pneumothorax that's putting pressure on the heart, you know, and pushing it, and it can't, you know, the flow through it is obstructed. Pericardial tamponade, which you'll learn more about in 4th level. But big one here, which we will talk about that can happen in kiddos, congenital heart defects. We have some obstructive defects, and so we can see, you know, them go into shock because of that. Cardiogenic shock is a pump problem. So the heart's unable to pump blood out to the rest of the body. So we have decreased cardiac output here, which leads to decreased perfusion, right? So cardiomyopathy, which we'll talk about when we get to cardiac, myocarditis, which is inflammation of, you know, the heart muscle. Heart muscle doesn't like to be inflamed. It doesn't like to do its job very well, you know, electrical conduction and pump wise whenever it's inflamed and angry or infected. And then again with, you know, obstructive congenital heart defects, that is something that we can see specific to peds that will cause cardiogenic shock. Also of note here, electrolyte and acid-base imbalances. So, you know, calcium abnormalities, magnesium abnormalities, but definitely potassium abnormalities, right? Anytime we have potassium abnormalities, one of our first thoughts definitely wants to be cardiac function, you know, electrical function, right? So then the fourth type is distributive. So then distributive has like three kind of subgroups underneath it. We will, briefly talk about sepsis and septic shock next week, but you'll get a very, very heavy dose of that in fourth level. Neurogenic shock you'll also get in fourth level, and then we will talk about anaphylaxis and anaphylactic shock next week. But with here, distributive shock, we have an abnormal distribution of our blood volume. So this is a blood vessel problem. Remember, we have a vascular tone of our blood vessels, right, which is neurologically controlled. And so with distributive shock, something is causing a decrease in our systemic vascular resistance. Our blood vessels are massively vasodilated. So we have massive vasodilation, and also frequently something is causing an increase in capillary permeability. So remember in patho when we talked about like inflammation and histamine and all those things, and histamine causes like leaky capillaries and all the fluid started shifting from within the blood vessel outside of the blood vessel. And so we weren't necessarily bleeding to death, right? But we have a relative loss of fluid within the vascular space. And so all of these things contribute to a decrease in cardiac output. So our interventions and stuff with shock, again, your book has table 35-4 with the different stages. If you'd like to review this just for foundational knowledge, that's great. I'm not worried about you getting in the nitty-gritty of the different stages of shock yet. That's a fourth level problem. Presentation is going to vary by stage, right? If we catch them earlier, they don't quite look so terrible, but frequently they will come in and they look very, what we call toxic. They take on this awful, like very pale, like almost green gray color, just because their perfusion is terrible. Cap refill is awful. Neurologically, they're altered. They might be tachycardic if we catch them early enough, but if they start to decompensate, we'll see them become bradycardic. Same thing with respiratory, tachypnic eventually, but then they will eventually get bradypnic, periodic, and then eventually, agonal and apneic. Hypotension, if we've caught them late, and they're no longer compensating with this situation, they will be hypotensive. And all the things that come along with that, right? Delayed capillary refill, poor perfusion, decreased urinary output, because if the heart's not pumping blood out to the rest of the body, we make urine from blood, right? Kidney perfusion is how we make urine. So if the kidneys are not being adequately perfused, we will see a decrease in urine output. And then just generally, they feel bad. They look bad. They might be febrile if, we're dealing with a septic situation. Our interventions, we want to find the cause and treat it, right? So we'll maintain our airway, breathing, and circulation. We're going to monitor all the vital signs, preferably continuously. There's lots of different labs that we'll get depending on what, the prospective cause is. We're going to give fluids and fluid boluses, plus or minus inotropes and pressors, plus or minus blood products if we're hemorrhaging. And then for certain ones of those, your obstructive and some of your cardiogenic, ultimately we might need a surgical procedure or some kind of procedure to relieve that obstruction, right? Sometimes it's a surgery problem. Or maybe chest tube, something like that. All right, moving on to ingestion. So synonymous with poisoning, right? And it can be purposeful or accidental. If you work PICU, you will see this very frequently, unfortunately. So our etiology and patho here, our cause is we got into something that we shouldn't have gotten into, right? Either purposefully or accidentally. And then the patho is obviously going to depend on the type of substance and the amount of substance. Of course, like I said, there are intentional situations here where the patient at that point buys themselves a PEC. They get PEC'd, possibly even CEC'd, and we're going to have, psych and mental health involved at that point as well, versus unintentional. I won't sit here and lie to you and tell you that I have not had to call poison control on both of my oldest children, one of them twice at this point. So it does happen, and we'll talk about prevention, but, I like to think that I'm a nurse mom. I like to think I'm at least, a decent mom, and it happens. I will say one of the times it was just because my oldest ate like 16 of his probiotic vitamins. It wasn't always crazy things, but my middle child, my second child, actually almost, could have gotten into some very, very dangerous, serious blood pressure medication, my mother-in-law's. So it does happen. It's easy to pass judgment, but it does happen. So table 35.5 goes over common substances, the most common substances that we see. Please review this. It all should be farm review at this point, but please, please, please be familiar with these. And it also goes over their antidotes and things like that, which we'll talk about in a second. But the presentation is really going to depend on the substance and what the substance is designed to do, right? If it's a medication, if it's a beta blocker, obviously they're going to present bradycardic and hypotensive, right? If it's an anti-diabetic medication, they're going to present hypoglycemic and likely neurologically altered. Really just depends. And unfortunately, ingestion is frequently unknown until the kiddo starts to exhibit signs and symptoms. And then, the parents or grandparents, whoever may have you, starts thinking like, oh gosh, like, could they have gotten into something? They go looking around the house, and sure enough, we find, like a opioid bottle open, or, blood pressure medication open, or, they got into a cabinet of some sort. So unfortunately, it's frequently unknown until symptoms begin. So our assessment here, we're going to do our ABCD assessment, our airway, breathing, circulation, disability assessment, address all of those, especially if we're in a life-threatening situation. If we can, we definitely want to determine the type and amount of substance that they took and the approximate time that they ingested it. Because flashback to farm, right? Pharmacokinetics, pharmacodynamics, all those like really silly words that you never thought that you would see again or have to use. Hey, here they are, and they're important, right? Because some medications we might not see initially, effects initially, but they have really long half-lives, right? So they need to be admitted. They need to be admitted to PICU. They need to be monitored because it has not started taking effect yet, but it's going to. And when it does, it's going to take effect with a vengeance, right? And then also, just to think about like, okay, at what point should the medication be cleared from their system? And then we're definitely going to cause poison control. A lot of times this has been done already, hopefully by the parent or caregiver, if not by the ER when they present to the ER. But poison control is our best friend in this situation. They call us to talk to us at least once a shift. And we like talking to them because they are the experts on the things that we are dealing with. And they will, most of the time, they're very polite, very kind. They give us really great recommendations on what labs to draw. Not us specifically, right, but the providers, give them, recommendations on what labs to draw, what worrisome signs to be watching for. They call to get, what's the most recent vitals, if we've drawn, levels. So like Tylenol is a really great example of this. Tylenol overdose, very common, very frequent. We will get an initial Tylenol level and then serial Tylenol levels, a couple times a shift after that, just so that we can hopefully monitor that and see it start coming down, after we have implemented our interventions. And so, poison control ask about that as well. And they're just really a wealth of information. Very, very helpful. Supportive care. Honestly, a lot of times is really what we do. Supportive care, we just support the organ systems until the medication wears off. So continuous, vital sign monitoring, of course, continuous like visualization and monitoring of the patient. This is an ICU patient. Neuro checks for sure. Frequently, every hour we'll do neuro checks. Definitely managing the airway with, all the things we talked about, potentially intubation depending on how severe the situation is. Oxygenation, plus or minus, fluids, plus or minus vasoactive medications, likely, depending on what they got into, maybe arrhythmia medications here, if they got into blood pressure medicines, or if what they got into is causing some gnarly acid-base imbalances in their body, we can see some arrhythmias with that. Sodium bicarb, this helps to, number one, if whatever they took has caused them to be acidotic, that helps buffer that, right? Bicarb is a base. Also, it helps to make the urine more alkaline, which can help to draw the medication into the urine to then be voided out of the body. So twofold, two benefit there. And then seizure management is going to be important in a lot of these cases, just because depending on what they took, it could cause seizures, right? So we will manage that as appropriate, which Dr. Wood will talk about seizure management towards the end of the semester. Decontamination, if it's something that's got splashed on them, that can burn them, et cetera, we obviously want to remove, remove their clothes, wash it off of them. If it's in their eyes, flush with water, all the common sense things, right? Activated charcoal is something that we can give, not given too terribly much, just because it's very time frame restricted. Um, Evidence shows that it works best if it's given within 1 to 2 hours of the ingestion. 9 times out of 10, they don't present to us in that quick of a time frame. So, also it's very, very not palatable. And so high risk of the patient throwing up as they're trying to drink it or take it. Or even if I've seen it, like EMS drop an NG tube, or ER, outside ER drop an NG tube and then administer activated charcoal via the NG tube. Almost always the patient throws it up. And so then it's almost like a more harm than good situation, because then we're putting them at risk for aspirating because they're likely neurologically altered as well. So, but it is something you might see. And then cathartics. A cathartic is something that makes you poop, right? So laxatives, with some things, if we can get it to just move very quickly through their gastrointestinal tract, they'll have less time to absorb it systemically, and then it won't have as much of an effect. But again, that's also one of those things kind of time frame sensitive. Directed therapy, so we have antidotes for specific medications. That table that table 35.5 has some of those antidotes. I will tell you the specific ones that I want you to be familiar with. So I do want you, for Tylenol, we give N-acetylcysteine or Mucomyst. It's terrible. It smells like rotten eggs. But a lot of times we give it IV, which is great. Narcan, of course, for opioids, right? Respiratory depressive medications. Digibind for digoxin. And then calcium for a lot of the blood pressure medication overdoses. So be familiar with those. And then enhanced elimination, we talked about the alkalinization of urine. HD is hemodialysis. Sometimes the patient is taken so much, or, with the smaller our patient, the longer it takes for them to metabolize things, they can store things. And so sometimes we do have to, reach for hemodialysis to try to eliminate the active metabolites of the drugs from their body. That's obviously a very sick patient. That's a pediatric ICU patient. And then we talked about charcoal. In some instances, we can give multi-dose charcoal if we've caught them in time. The worry with that, of course, in addition to what we talked about, is also it can form like this brick of medication within the patient's bowels. And so then you've, number one, got like a bowel obstruction that you have to deal with, which nobody likes those. And then also it's just this like brick of medication that the patient's body is just breaking down and absorbing. So like I said, charcoal, great in theory, but the follow through, not great. Again, with that, prevention is key. Lock the stuff up. Watch the kid. Like, you can do all the things right, but like nothing takes precedence, and nothing is as good as actually just like watching the kid, right? But definitely lock everything up. Don't treat medicine as candy. Your book has patient safety 35.1 box that goes over prevention mechanisms, and then absolutely call poison control. They have this really great less embarrassing thing now that you can do, where you can go online and fill out this thing, and you can say what happened, what they got into, et cetera, et cetera. And it's nice. It gives you like this recommendation, like, yeah, you should probably go to the ER. Like, no, you're probably good to just watch them, but make sure you watch for like XYZ. And then it's really nice. Like, they follow up with you via email, every 12 to 24 hours. Again, don't ask me how I know. I know because I have 3 children. But it's nice because you don't have to do the embarrassing thing of actually talking to a human. All right, non-accidental trauma. I do believe this is our last topic. Yay! We'll have time for active learning. That's so exciting. So non-accidental trauma NAT. This is on page 758 to 761 in your book. So neglect, child abuse, right? Again, not all rainbows and butterflies. I told you I worked this past Saturday. This was absolutely a neglect situation that we were dealing with. And it was very, very, very crucial, very serious. So, lots of things fall under non-accidental trauma. Physical abuse. So this is, purposeful inflicted traumatic brain injuries, purposefully inflicted fractures, bruises, burns, things like that. I've listed triggers. one of the biggest ones is crying, especially in infancy. So everyone's probably heard of shaken baby syndrome, right? Very easy to pass judgment. Very easy. Oops, sorry. Very easy to, say I would never do that. That would never be me. But one of the hardest parts of peds, I think, being a nurse in general, but also peds, is it's not our place to judge, right? You can feel your feelings, but it's not our place to judge. But because until you've been in the specific situation that someone else has been in, you honestly can't know how you would react. And of course, this is why, like, newborn support and parental support in the neonatal, those first couple months is just so important, because things get, it gets rough when you haven't slept in 4 days, right? And so, like infant crying is a very, very, very big trigger. Nighttime awakenings, babies not wanting to, sleep at night, and parents want to sleep at night, need to sleep at night. Toilet training toddlers, they're trying the I do it phase. Oh my gosh, took years off of our lives, right? Like I do it, I do it. That's just their developmental stage, right? Like they want to do the things, they want to be independent as much as they can be, but like they can't wipe their butt themselves, and it can be very frustrating, right? Or you're trying to potty train and it's not going well, and it's just very frustrating. The kiddo who goes to the fridge to try to pour themselves a glass of milk or juice because they just want to help and they want to do it themselves, but they inadvertently spill the entire thing of juice, right? These are all things that can be triggers. We do see a higher incidence with poor or lower socioeconomic status families, individuals, if caregivers use drugs or alcohol themselves, if caregivers have mental health issues, kiddos with special needs, just a lack of knowledge, honestly. Some people, we use the term, they're very simple. And you will be surprised when you get out there if you have not experienced it yet. It's very shocking how simple some people are. And so just a general lack of knowledge a lot of the times can, trickle into a neglect situation. If the caregiver has a history of abuse, their childhood or adulthood, young parental age, and then, like I said, lack of support. Parenting is a full-time job, right? 24/7, you don't get any breaks. And it's hard with two parents. No idea how some people do it with one. Kudos to them. Sexual abuse also falls under this. Does not only include penetration, it includes any sexual acts, any genital exposure, prostitution falls under this, child pornography, all of those things. Emotional abuse, neglect. So, medical neglect, meaning, the child needs medical care and they're not getting it. So, kiddo we took care of Saturday, has seizure disorder, and taken her seizure medications in 3 days. So obviously it's going to start seizing, right? Uncontrollably. So that is, that's medical neglect. We also had lots of signs of physical neglect. So this is where, likely you will see a failure to thrive case. I think we saw 2 on our floor, on the floor where we did clinical and A term. Super common, very heartbreaking. And then also exposure to domestic violence falls under this as well. So some red flags for non-accidental trauma, because remember, we are mandated reporters, right? And this can be a very difficult, very uncomfortable situation because our duty is to the patient, right? Parent can be very, very sweet. It can be a very sad situation, a very understandable situation. Our duty is to the child. Our duty is to the patient. Our duty is not to the parent in this situation, which I feel like is difficult because we harp on you a lot that, like, basically the parent and the kid are one in peds, right? But we do get to a point where we have to separate that and we have to differentiate that and we have to protect the kid. So some red flags: vague description of injury or illness. The injury doesn't match the story or the developmental level of the child. So, a 2-month-old or, a 2-week-old, 3-week-old, whatever, is not going to pull down a, and this is just obviously very, very ridiculous and obvious, but just to give you an example, an infant, who's not even crawling is not going to pull down a pot of boiling water and burn themselves, right? Developmentally, they're not going to do that. So, you always have to compare like developmental level and what's expected, what's reasonable, what's realistic that the kid could have done, and if it's not realistic, then odds are it didn't happen. So, also multiple versions of the story, especially multiple versions of the story by the same caregiver, but also just multiple versions of the story from different caregivers, and a delay in seeking care. So what I have personally found, and I don't mean for it to sound harsh, it's just fact of the matter, is if something happened accidentally, a true accident, there's no hesitation to bring the kid to the ER because they want their kid to be okay. They want their kid to get the help and the treatment that they need. If something did not happen accidentally, the only time that we bring them in for treatment is if we're worried they're not going to make it, because then at that point we're facing much, much more severe charges, right? So delay in seeking care. Remember, and we'll talk about this with musculoskeletal, bones in kiddos are a lot more cartilage, right? They're a lot more cartilaginous. It's a fun word to say. Meaning they're not ossified completely until they're older. So their bones bend more before they break. It's a lot harder to break an infant or a kid's bones, infant, young child, than it is an older child, adolescent, adult. So when we see broken bones in infants and young children, certainly accidents happen, right? Like I broke my arm twice before I had turned 3 years old because I'm just feral, I guess. I don't know. So accidents do happen, but big fractures, long bone fractures. So, like humerus, femur, tibia, fibula, spiral fractures where, the fracture literally, spirals around the bone. That's caused by like a yanking or a twisting motion. Those are always really big red flags for non-accidental trauma. Skull fractures, big red flag for non-accidental trauma, especially if we see fractures in various stages of healing. And so I've actually, found non-accidental trauma cases inadvertently when a kid comes in with like respiratory, distress, and we get a chest x-ray and they've got a slew of, previously healed rib fractures. So that's a big red flag as well. Needs to be investigated and reported. Bruises on the trunk, head, or buttocks. So typically like non-bony surfaces, right? Once they start, like crawling and pulling up and all the things, they fall. They do fall, right? Especially little boys. Lord have mercy. And I know Dr. Wood and I always laugh about this because she had boys, and I've got two. And I tell mine all the time, like, can y'all please just try to be like a little bit more careful? Like they're gonna think that we beat y'all because they're just rough and there's bruises all over their, like shins and knees, and like they hit their head on stuff, and they got the goose eggs and all the things. But if we've got bruises on the trunk, bruises on the face, bruises on, lots of bruising on the head, especially if, you can tell what they were struck with, like you can see a handprint, you can see like a bruise in the shape of a hand, or like a belt loop, a rope imprint, something like that. That's a really big red flag, especially in a kiddo that's less than 6 months old. So general rule of thumb here, the little, cute little ditty that we say is if they don't cruise, they shouldn't bruise. So if they're not pulling up on furniture and cruising around, trying to learn to walk, and, there's no reason for them to be like falling down and potentially to have bruises. If they don't cruise yet, they shouldn't bruise yet. So that's a red flag. Any genital pain, any genital itching, discharge, any, genital blood, obvious presence of an STI or obvious trauma to the genital areas, of course, is a direct referral. We'll call the same nurse, and that's obviously immediately reportable. Kiddo might complain of vague somatic symptoms, so vague body symptoms like their stomach always hurts or they always have headaches, especially if a particular caregiver is around. That's a really big red flag. They don't want to go with someone. They don't want to be with someone. They don't want to be left with someone. Huge red flag. Inappropriate sexual behavior that they shouldn't know about yet. Huge red flag. And then development of enuresis or, like they were previously potty trained and now we're having bedwetting. Now we're having accidents again, especially when only a certain person is around. Huge red flag. So just some pictures. You'll learn more about brain bleeds in 4th level. But top left is a subdural hematoma. So with a midline shift, meaning there's so much bleeding in the brain that the brain matter is being shifted to the other side of the skull. These are highly indicative of non-accidental trauma. Bottom left is a femur fracture, spiral femur fracture. So hopefully that puts into, perspective, like how much force it takes to break a bone that big in a kid and to break it that way. Bottom middle, those are retinal hemorrhages, very highly indicative of shaken baby syndrome. So that is one thing you'll see they do pretty standard is they'll do a retinal exam when we have a kiddo that comes in with suspected abuse, shaken baby syndrome. And then we go over burns a little bit. You'll get burns more in 4th level, but we go over burns more in the integumentary voiceover PowerPoint. And I hit on this a little bit there. But top right picture is just, top right is bruising. So what we talked about, right? Like accidental bruising patterns, more so, bony areas, that kind of thing. Whereas like abusive bruising patterns, typically softer areas of the body, right? And then bottom is, big no-no, big red flags for burns. Anytime it looks like a child was forced into, a thing of water to be punished. If it's a circumferential burn or it looks like, gloves or socks, that kind of thing. They can be very, it's just some patterns are highly indicative that it was not an accidental burn. So again, we're mandated reporters. Even if you're not sure, bring it up, right? Bring it up to the doctor, bring it up to the nursing supervisor, at the very bare minimum, the charge nurse. Not to say we want to report every little thing, but it's better to err on the side of caution and it not be anything than not report it and the kid continues to go home and is discharged with an abusive caregiver, right? So we're often the initial point of contact, especially in the ER. But very much so PICU, PEDS floor, school nurses, really anywhere where you work with kids. So teachers, same thing, right? We want to put a detailed note in their chart, use quotations for what the patient or the caregiver said, like verbatim, word for word. And that way you can print that and you can give it to Child Protective Services or whoever comes to the hospital. We don't ever want to interrogate the patient or the caregiver. Let the people who are trained in doing that, the professionals in doing that, do that because you don't want to give them time to come up with a better story, if that makes sense. You don't want to give them, an advantage. You don't want to ruin anything, right? You don't have to, you don't have to do that. Your duty is to the patient, to protect the patient, right? That's our number one concern. So you by no means have to memorize all of these. Your book is just out, your book has the front half is all the different case study chapters, whereas the back half is like the content chapters. And so I went through and just picked out, some of the potentially helpful tables or boxes, et cetera, throughout the book. If you're more of like a table, visual kind of person, I tried to go through and find them all because they're kind of interspersed throughout the book. So, and there is a really great, 1-minute nurse video on shock. I think I also, the little thing above where your PowerPoint is on Moodle has some of the other things on the point that would be, helpful if once you study and, you're getting to the point where you want to start practicing applying the information, they might be kind of helpful. Let's see, I have 10 minutes. So let's back out of this and let me just share my, let me just share my screen. That'll be easiest. So let's go to Moodle and, no, extend my session. So let's look at this case study. All right. So let's start off. So we've got this kiddo. She's 6 months old. Gives you her weight. So she presents, and this made me giggle. I think it says like Canadian or something because it's 811 instead of 911. But presenting complaint is noisy breathing. So temp 38.4, which I do believe is febrile. Heart rate 180, blood pressure 86/52, respiratory rate 60, sat 88% on room air. That glucose is normal. Whatever the conversion is for that is normal. Her GCS is 15. So triage note, recent viral illness, going through the household. But this morning her breathing sounded very noisy, so her parents called and they were sent to the ED. Her past medical history, she's got really nothing. She was born via uncomplicated spontaneous vaginal delivery. She was a term baby. She's never been admitted. Her vaccinations are up to date, and she's got no family history of respiratory issues, and she doesn't take any home meds. So let's see. Alec, what do you guys think about? Like, tell me about her vital signs. Like, what do you like? First impression. What do we love? What do we not love? Like, what's our initial like first impression?
Respirations are good. Talk a little bit louder. Her heart rate's elevated.
Heart rate's definitely elevated.
O2 is low.
O2 is low. Good
This
deal.
side.
So we
Okay.
definite fever. So yes, so heart rate is, she's definitely tachycardic, right? But we'll talk about this, could be contributed to her fever, right? Fever increases metabolic demand. So definitely tachycardic. Blood pressure's okay. She's 6 months old. I'm cool with that blood pressure. Respiratory rate 60, not awful for a 6-month-old. But in light of, the respiratory issues going on, I definitely want to watch it, right? And I definitely don't love that sat. Probably want to, throw her on some O's, right? All right, so let's see. And she's got nothing in her history. So more of our assessment, we're looking at her. We got some snot rockets, right? We got some nasal congestion, some drainage, and then let's see if it'll play from right here. It'll make me really happy if it does.
You deserve the best.
Nope.
And I'm afraid you can afford it. It is only a relative.
Thanks, Harbor Freight. All right. So then this is what we're seeing when we're assessing. So definitely retracting, right? He's working. Or she's working. You can definitely hear all the congestion, right? So that's a severe asthmatic, but so that's what we're seeing when we're assessing her. So we don't love that, right? She's working pretty good. And then let's skip to this. All right, so we put her on the monitor. This is what we're seeing. So we said heart rate 180, sat 88, respiratory rate's now 70, and blood pressure is a little bit lower. So Shreveport, yell out some things that you would like to do. What are some interventions that you feel are appropriate and necessary? Are y'all there?
Yeah, you had muted us earlier, so I had to think about it for a second there. All right, they're hollering out.
Okay, holler.
Reposition.
For sure. Oxygen. Definitely suction. Definitely oxygen. Maybe start with a little nasal cannula, see if that, does the trick, but might have to escalate, right? What about that temp? What do we want to do? What do we want to get an order for?
Want to know how old the child
It's
is?
a 6 month.
So they can have
Tylenol.
right, Tylenol or.
Right. Yeah, and we're 6 months, so we could do ibuprofen if we needed to, but probably, first reach for the Tylenol. Because if we can bring that temp down, that heart rate's probably going to come down, right? And respiratory rate might come down as well. But treating the fever is not going to fix the whole respiratory just because we've obviously got something going on, right? Okay, great. So yes, we heard suction, we heard, antipyretic, oxygen, reposition, all the things. So maybe circulatory wise, we probably want to put, start an IV, right? And maybe get a little fluid bolus. She's probably kind of dry. Might be why we're tachycardic as well, because less volume, our heart's gonna try to compensate, right? And especially this blood pressure is, a little borderline low. This mean arterial pressure, I really would like to be at least 60, right? So we're struggling a little bit. And she's probably been febrile for, a couple days, tachypnic for a while. So all these insensible losses, right? And then it's hard when we're having difficulty breathing. We don't really want to drink. Like if we have to choose between eating and drinking and breathing, we're going to choose breathing, right? So PO intake might not have been great, the last couple days. So we're probably very volume depleted. So we'll probably get an IV if we can. And then get a little bolus going and then definitely get her on some maintenance fluids. So let's get more of the history. So 4 days ago, older sibling who recently started preschool, germ infested, had a cold, and they love to share the things that they don't need to share. So then, next day, sweet little nugget fell sick. She's had a runny nose and cough, but seemed to be doing okay. Like we said, probably stopped eating and drinking. We don't like that. Had some noisy breathing and her chest looked funny, like we saw. And it didn't go away. They called, went to the ED. She has not urinated today, so that's not good, right? That's always something we want to ask. When's the last time we pottied? And so definitely want to get some fluids on board. Had a bowel movement yesterday evening. That's great. Love that. We could ask our favorite questions, right? Like, what did it look like? What color was it? That kind of thing. And, they said it was normal. But otherwise, she's happy, healthy, all the things. So let's see. Which of our findings, we'll go back to Ellick. So let's look. We already talked about the tachycardia. Do we love that capillary refill? No, right? That's prolonged, which also makes sense because blood pressure was starting to trend down, right? And it's 4 to 5 seconds centrally. Ugh, I really don't love that. Really don't love that. 6 seconds peripherally. Yeah, I'm going to start moving a little bit quick, right, with that. Neuro-wise, she's alert though, so that's good, but she's probably fussy and irritable. We saw the nasal flaring. She's grunting. We don't love that, right? And retracting all the places. And she's got crackles and wheezes on auscultation. Her mouth appears dry. So again, dehydrated, right? Abdomen is good, soft, round. And then otherwise her skin is okay. So let's see. We talked about, I got a little ahead of us, didn't we? We got a little ahead of ourselves. So we definitely said we wanted to start oxygen. We suctioned her and she just got copious nose boogers. We said we want to throw an IV in. We'll give a fluid bolus. We talked about antipyretics. So as far as like other meds, now that we've got a little bit more respiratory data, what would we want to do, or what would we expect orders for?
Steroid, mucolytic.
Okay, I heard steroid. I love that you said that. And you will see it done with bronchiolitis. Evidence is kind of like positive, negative, maybe steroids might, maybe not, but in severe cases, absolutely. I heard mucolytic. We can do some inhaled stuff. You'll see some inhaled stuff done. Yes, labs. I love that. What labs would you like for me to order?
Probably a CMP. I don't know, basic metabolic.
And
Right. So yeah, we could do definitely CBC, right? So
Yeah.
we'll get a white count on that. CMP for sure, or at least a basic metabolic panel to check our fluid, fluid status, electrolyte status, acid base balance for sure. Oh, what about respiratory wise? What could we How could we
Right.
determine? Love it. Blood gas, yes. Maybe like a respiratory virus panel to see what like the culprit is, right? Okay. And then maybe nebulizer treatments, right? So they were wheezing. And so we could probably get some albuterol, inhaled albuterol on board. Let's see. And I'm just going to finish this slide and I'm going to let you guys go. I'm trying to get back down to my, there we go. Let's see what else. So labs, yeah, CBC, CMP, ABG, or maybe a VBG, and then probably a chest x-ray as well, just to look, right? And then definitely going to have respiratory therapy on board. Probably a good idea to check her sugar. She's had like poor PO intake, right? And she's been stressed. All right, great job, guys. I'm out of time. So thank you for listening today and participating. It's always a lot more enjoyable when you guys participate. Email me with any questions, or you can shout them out right now if you need to. But I will have the recording up as soon as it's available to me.
Stop.